tell me that?
Well, the reality is that this is a new virus.
The earlier the better for most of these things. There are some patients who've been in the hospital for a month.
I wanted to be assigned in the worst place they had. I wanted to be put with the sickest patients they had. And so I sort of laugh at that now because that's exactly what happened.
And we're still figuring out the biology of this virus and how it works or how it infects people.
Let's just go ahead and say maybe there's a chance that I have it and don't know it. So because I care about my neighbor.
Now what we're faced with is managing our healthcare resources.
People are still getting sick from everything they used to get sick from. So the other viruses and other illnesses and cancer and other stuff has not gone away. People still need a lot of care.
The virus part may be gone, but now they may be into the clotting or the cytokine storm piece.
We should care about every infection that happens anywhere in the world that has the potential to affect us.
I would know if I had it. I'm kind of invincible mentality. I would just say that in the middle of a pandemic is not really a time to test that.
I was doing everything properly and wearing the equipment as it was designed to be worn. But still in the back of your mind, you're wondering, is this enough?
Distance no longer matters. Physical distance is just non-existent. Meaning I can be in Hong Kong within 24 hours before I even know I'm sick. And that's ideal for transmission of infectious agents such as coronavirus. And this is why it became a global pandemic within weeks.
Hi, my name is Dr. Stephen Farrell. I'm the Chief Medical Officer at Forrest General Hospital here in Hattiesburg.
My name is Dr. John Fitzpatrick. I'm a nephrologist and president of the Hattiesburg Clinic.
My name is Susan Dobson, and I'm a lecturer at the University of Southern Mississippi.
I'm Dr. Stephanie Kelly Parks, and I'm an assistant professor at the University of Southern Mississippi.
My name is Mohammed El Asri. I'm a scientist at the University of Southern Mississippi. My area of expertise is infectious diseases.
In April, I received a phone call from the military, and quickly I was asked two questions. Was I healthy? Did I feel good? And I said yes. And they asked if I was symptomatic or experiencing any signs of COVID infection, and I said no. I was told that I was being mobilized in a type of unit that I had never even heard of. It was going to be a military urban augmentation COVID task force. 17 hours later, after getting the call to mobilize out to California, where I met up with approximately 85 other healthcare professionals that were just like me, had been at home, and the military had decided to mobilize a large force of healthcare professionals. So we left California, and I ended up in Philadelphia, Pennsylvania, where I was assigned to work at Temple University Hospital. We had several military members that were already on some of these augmentation task force, and so we did a huge networking of resources, how to treat COVID positive patients, how to don and doff, how to utilize PPE, how to not exhaust the supply system so you don't run out of PPE. So we had a lot of training going into that, and it was that training that helped me integrate at Temple University. And so I also remember whenever I was first getting to Temple, we were asked where we wanted to be assigned, and I remember, being an Army officer, I remember telling the hospital administrator I wanted to be assigned in the worst place they had. I wanted to be put with the sickest patients they had, and so I sort of laugh at that now because that's exactly what happened. We had a quick orientation, and then the next day I was on my first 12-hour shift of the rapid response team. And I remember at 10 o'clock in the morning, my first shift, there was a patient that was requiring intubating. And I remember rushing to the patient's room, and a large crowd would gather outside the room, which was new for me, because usually whenever you had a patient that was very sick, you had several people in the patient's room helping out, performing a task. And this was the first time I realized that there was nobody running into the room because of the pandemic, the virus, and how it spread. So only a limited amount of people were going into the room. And I remember putting my gear on, my N95, double mask, gloves, the disposable gown. I remember wearing face shields. And I remember walking into the room carrying as much stuff as I possibly could because you weren't going to be going in and out of the room. Wearing all of that, and I remember looking down at this patient and thinking, I hope with all of this gear on that I'm able to do the job that I'm here to do. I'm wearing more gear than I've ever worn in my life to do the job that I've always done. But I was thinking, I hope this happens as it's supposed to. And another thing is, I hope all of this stuff that I'm wearing works, because one of my greatest fears is becoming COVID positive myself, and not then being the person that helps and assists these patients, but then becoming someone that's requiring medical care myself. And we did have more than one member of my task force that did become COVID positive from our deployment to Philadelphia. So all these things were going through my mind, and this is when I first got there. And it was scary. It was a scary moment for me personally as a healthcare provider, because we're doing everything that we were shown to do. I was doing everything properly and wearing the equipment as it was designed to be worn. But still in the back of your mind, you're wondering, is this enough?
The reason it has been very successful at spreading fast and wide is a combination of features that this particular virus seems to have. One of them is its ability to survive on surfaces for some period of time, which means that if I deposit it on a table or touch a surface and then you touch that and put it in your mouth or nose, then that's going to get passed on. The other one is really its transmission through aerosols, which is one of the quickest, easiest way for a virus to go from one person to the other. And then of course, once it gets into the human population, the reason, especially for a virus like this, the reason that you'll see it in a highly dense population is because it's easy for a virus to spread in a dense area. Especially if it's a new virus, people are not looking for it. You may present illnesses that if nobody knows about it, they may treat you for other things. And until somebody makes the discovery that this is a new agent, then you can start tracking it. So it makes sense that it spreads well in dense areas.
What we're learning more and more about COVID-19 is that we have pre-symptomatic and asymptomatic populations. Pre-symptomatic are individuals who just don't have symptoms yet. Asymptomatic people are people who do not and will not have symptoms.
From the time you're exposed until the time that you develop symptoms, if you're going to develop symptoms. Initially, we felt that, and it was actually promoted, that you were more likely to transmit this disease when you were symptomatic. I'm sure you heard that back in March. Now it looks as though you are able to transmit the disease within about 3 days prior to being symptomatic, which would be the pre-symptomatic phase.
One of the interesting things about this virus is the fact that a large number of folks that get infected don't show any symptoms. It is good for those that don't show any symptoms, but that also means that a large number of the population can carry it and spread it unknowingly, without seeking treatments. And so that's what allows it basically to spread very easily.
As we do hear a lot of people say, I don't have coronavirus, I feel fine. And that's just a not understanding how asymptomatic or pre-symptomatic works. Most people think that if they are not sick, they're well. And that is not the case. That doesn't just apply for COVID-19, that applies for just about all illnesses. You can never assume just because you don't feel sick that you're well. There can always be something going on that your body hasn't told you about yet. sometimes our body doesn't ever tell us. I mean, we certainly hear about people who have had sudden death from heart attack or stroke who didn't have a prior history of heart disease, right? So they didn't know that they were sick.
We know that a large portion of patients, a large proportion of the patients can be completely asymptomatic. We don't know to what extent they are spreading the disease. But if they have the virus and it's present in their body and they're breathing it out to someone, logic would tell you clearly you can spread the disease. So that was one of the reasons a lot of people said, well, we should just test everybody and find out who has it so that they don't, we can tell them to quarantine. But in my mind, asymptomatic people can spread the disease. They can also have complications if they have no illness and they aren't showing signs of it, but if they go on and have anesthesia and surgery when they have this illness, even though they're not showing symptoms, they can have worse outcomes from the surgery because of the illness. So being asymptomatic is good for you in that you don't feel bad, but it doesn't get you away from the whole effects of this disease playing an important role to the people around you until you're potentially getting ill yourself.
The best way to prevent or slow the spread of COVID-19 is through primary prevention measures. There are 3 levels of prevention that we use in public health to help prevent or delay consequences or negative consequences from illnesses or injury. And those 3 levels are primary prevention, secondary prevention, and tertiary prevention. And right now, what we know about COVID-19 and the tools that we have to fight this illness, majority of the things that we need to do to slow or stop the spread is in the area of primary prevention. And primary prevention is our first line of defense against any illness or injury. We're already very familiar with some primary prevention measures, things like wearing our seatbelt or washing our hands. Those are primary prevention measures. Primary prevention is designed to prevent healthy or uninfected people from becoming sick in the first place. Direct contact with the virus is when an uninfected person gets in close contact with an infected person. So the transmission or the passing of the virus from one person to another is person to person. Direct contact is the transmission for direct contact happens through respiratory droplets. Respiratory droplets is the watery substance that would leave a person, an infected person, when they're talking, when they sneeze, when they cough, when they sing or they shout, anything that would project respiratory droplets into the space or the air immediately in front of them. Respiratory droplets that contain COVID-19 are believed to be larger and heavier, and so hence the 6 feet of social distancing. The heavier respiratory droplets fall to the ground very quickly, and so the droplets that contain COVID-19 do not travel more than 6 feet, based on the research that we have currently. So social distancing is the primary prevention measure that prevents direct contact with the virus from person to person by just spreading people out a distance that doesn't allow the virus to travel that far.
What we're asking people to do is to do how can you live your life to the fullest extent in this environment right now and with the best potential to not spread the illness. And the really 2 things that you hear over and over again are wear your mask and appropriate social distancing. And that magic number is approximately 6 feet. And then the mask has to be worn over the nose and the mouth when you're in close proximity to people. It's to avoid extended periods, even with masks, but avoid extended periods in close proximity, sharing air, and that time period is about 15 minutes. So it's the 6 feet, 15-minute rule that you've heard mentioned. And then wearing the mask, I think that when we first started this out, we all were concerned about wearing what's called an N95 mask, which is a very high particulate matter mask, which we use in the hospital when we go into a room of a patient who we know has COVID. Then we would wear an N95 mask to protect ourselves from getting the virus from them. However, what we do know is that if everyone in close proximity to each other wears a mask, that the risk of us sharing virus through the aerosolization or the micro droplets that it lives in as it's spread through the air, the risk of that is less than 5% if we both wear our mask. If one person wears their mask and the other one doesn't, then the risk is to the person not wearing the mask. All right, and so it's a matter of both people wearing their masks dramatically lowers the risk if they wear them appropriately. And then if you're around someone with COVID, it's wearing the right kind of mask, an N95 style mask, so that you don't breathe in the droplets that they have. And you've heard people in different states talk about, well, I believe there was a politician in Texas who said he contracted COVID off of his mask. That's just absurd. You didn't contract it off of your mask, you contracted it because you wouldn't wear a mask, and now you're wearing a mask and it's too late. So at the end of the day, wearing a mask and staying an appropriate distance apart from people, certainly in large areas.
Now, one of the things we've heard about masks is that maybe they're uncomfortable, or maybe there's a concern about whether they trap carbon dioxide, or whether rebreathing your own air can be harmful to your own health, if some of these measures are not good for your immune system. So maybe you've heard some of those types of rumors. So there's no evidence that any of that is true. The carbon dioxide that you're exhaling would travel through even the 2 layers of cloth mask that would be recommended. It's very, very small, and it would be able to travel through. So you're not trapping a lot of carbon dioxide inside a mask. You're getting oxygen in through the porous in the cloth, as well as getting carbon dioxide out. And that might be hard to understand because some people think incorrectly that, well, if carbon dioxide is escaping and oxygen is entering, then surely the virus is also entering and exiting. But remember, those respiratory droplets are larger and heavier, so they actually don't leave the mask area. They fall inside the mask and are trapped that way. But still, the individual wearing the mask can remain healthy with good oxygen exchange, and you don't have to worry about those things that you might have heard about carbon dioxide or some of the other myths about the health of wearing a mask.
I think I'm not a fan of closing down society and closing the economy. I think we have to find the balance in how we live our lives and minimize our risk to the best of our ability. And that means that when I'm around my grandchildren who are in school, I wear a mask because I don't want to catch what they may have had at school. But that doesn't mean that I don't see my grandchildren. We don't get that close right now in these present times, and everybody's okay with that.
Indirect prevention measures are when you pick up the virus from surfaces or contaminated objects. And we have 2 primary ways of protecting from indirect contact. And that is the old-fashioned of washing of our hands. And we want to do that for at least 20 seconds with soap and water. And we want to vigorously wash our hands. And this is a really good practice even when we're not in the middle of a pandemic. But the purpose of washing our hands to protect against COVID-19 is to prevent transfer of the virus onto our hands, and then we would touch our face, nose, or mouth, and that would cause us to contract the virus indirectly. The other way to prevent indirect transfer of the virus is cleaning of surfaces. And this is an important public health measure, again, when we're not in a pandemic, but it's really helpful for COVID-19. So we want to clean surfaces regularly in high touch points like doorknobs or bathroom fixtures. Again, indirect transfer can be prevented when we clean surfaces and the virus is not transferred indirectly from a surface to a healthy person. So these 4 prevention strategies are primary prevention. Another primary prevention strategy is vaccination. And we don't currently have a vaccine for COVID-19. We do hope to have one in the future. And a vaccine would be, again, a really great primary prevention tool in preventing or stopping the spread of COVID-19. But without that vaccine currently, we really have to rely on these behavioral things that we're asking people to do. When our primary prevention measures fail, we have to rely on secondary and tertiary prevention measures. Secondary prevention measures are aimed at early diagnosis or detection. And this is where the emphasis on testing has come for COVID-19. We must test in order to identify individuals who have the virus early. The best way that secondary prevention helps us if we can identify individuals before they become symptomatic or contagious. So the earlier the better. This is where contact tracing is very helpful. It lets us know who to test next. They may not have any symptoms. So some terms you may have been hearing about recently are pre-symptomatic or asymptomatic, and you might not be sure what those things mean. Pre-symptomatic is before the virus builds up in a person's system and makes them ill. Many people are pre-symptomatic, so they don't have any symptoms initially, but they're contagious. And then asymptomatic are individuals who never have symptoms. So they have COVID, they can transfer it to another person, but they actually never had any signals from their body that they were sick in the first place. And this is where secondary prevention can be very effective. It helps us identify people who are asymptomatic, who never have any symptoms of the illness. And this helps us put interventions into place to protect the larger community. And this is where you're hearing things like quarantine and isolation. Those are secondary measures when our primary prevention measures have failed us. And then finally, if primary and secondary prevention measures don't work, we rely on tertiary prevention measures. And tertiary prevention measures are the most expensive, the most inconvenient. They're the ones that happen in healthcare settings or hospital settings. And this is where we get treatment or rehabilitation. Many people who get sick with COVID-19 do get sick, and some of them get severely ill, and they require hospitalization, ventilation. All of these are tertiary measures. In the fight against COVID-19, what we want to do is we want our first line of defense, those primary prevention measures. And if not primary, we want our secondary prevention measures to work. If we're able, we want to avoid any tertiary measures because, again, those are most expensive, and that's after a person has gotten sick, and we want to prevent them from getting sick in the first place.
So the first treatment option is a medication that blocks the replication of the virus in cells in the body. It's basically an antiviral medication, and that medication is called remdesivir, and it's given intravenously, typically for 5 to 10 days, and has been shown to reduce the duration of the illness from 15 days down to 11 days. The second category of agents that are useful against the virus are antibodies. So antibodies are proteins that are made by the immune system to fight viruses. And from patients, we can recover antibodies from patients who've already recovered from the coronavirus infection and then subsequently administered to patients. And these antibodies are typically targeted against a protein on the surface of the virus called a spike protein. And the spike protein of the virus is what the virus uses to get into cells, such as cells in the lung. So if you block that spike protein, you block the entry of that virus into the lung cells so it can't replicate. The second approach using the antibodies is there are companies who can manufacture these antibodies, and they're called monoclonal antibodies. And there are some trials underway studying the efficacy of these agents in patients infected with COVID-19. So a lot of these things are still being evaluated in clinical trials, but there is data to show that the plasma is beneficial, just like the remdesivir. None of them are a cure. They all shorten the duration of the illness. So they make a dent in it, but there's no cure for it. A third area where treatments can be targeted is patients who have COVID-19 infection are prone to excessive clotting. Clots can form in the lungs, the kidneys, the heart, the brain, and other organs and cause organ failure. And in an effort to prevent those clots from forming, most patients, when they're admitted to the hospital, are treated with blood thinners, such as subcutaneous heparin, to try and prevent the clotting that may happen down the line. And there is data to show that that is effective. It doesn't prevent all the clotting, but it reduces the amount of subsequent clotting. Again, makes a dent, not a cure. The final area of targeting for treatments is the inflammatory system. In some patients, COVID-19 infection causes excessive inflammation, and there is a treatment for that called Decadron, which is a steroid which is given intravenously, and it's been shown to have a significant benefit in patients with that complication of COVID-19 infection. It's definitely improved the mortality in that subset of patients by at least 20%. Finally, there are supportive therapies that patients receive while they're in the hospital with COVID-19. Probably the most important one is oxygen therapy. Most patients who are hospitalized with COVID-19 infection have low levels of oxygen, and hence they require oxygen therapy. So there are different forms of getting that oxygen therapy, be a nasal cannula, face mask, or ultimately ending up on a ventilator with what's called mechanical ventilation. But there are also maneuvers that we can do with patients, such as flipping them over onto their stomach. That's called proning the patient, that actually improve the oxygenation, improve the delivery of oxygen by flipping the patient over. So those would be supportive therapies to improve the oxygenation. In patients in the intensive care, many of those have low blood pressures, and those require infusions of medications to bring up their blood pressure. And then finally, for patients who develop kidney failure and dialysis, the most common form of dialysis used in patients with COVID-19 is called CVVHD, or continuous dialysis, which is more appropriate for patients with low blood pressure in the intensive care. This is a slow, continuous dialysis, which is more useful in patients who are in shock with low blood pressure. So ideally, you do not want to end up in the hospital with COVID-19 infection, so there's a big focus on prevention. And until we get a vaccine, I would strongly recommend that you wear a mask, socially distance, and wash your hands for 20 seconds, or use hand sanitizer, especially after touching objects that you don't know who last touched that object, such as a doorknob, etc.
So nowadays, one of the challenges with access to testing, which is critical to control spread, is that a lot of commercial labs are basically overwhelmed by the demand. And so tests nowadays take anywhere from 5 to 7 days to get results back, which is not practical, not very useful. And so here at the University of Southern Mississippi, we have developed basically testing capacity inside our campus so that we can have a quick turnaround. Within 24 hours, we get results back. This test involves swabbing, collecting some cells that may carry the virus, isolate its genetic material, RNA, go through a technique called the polymerase chain reaction, or the PCR reaction, which allows us to detect the genetic material of this virus very carefully, very sensitively, and then it allows us to identify or figure out whether somebody is infected or not. And this is part of the effort of managing spread within our campus, so that we can very quickly identify people that are positive, and this followed with contact tracing, which means that if you are found to be positive, then we have a mechanism to identify other folks you have interacted with and have them tested as soon as possible, get the results as soon as possible, and then take measures. And this is a good way to basically minimize or control the spread of the virus. My hope is that soon We will have more rapid tests that are a lot faster, a lot easier, and a lot cheaper. In fact, the technology is already out there, but hopefully manufacturers will catch up so that it's even easier and faster and cheaper to detect folks that are carrying the virus. And my hope is that within a year, we will be to a point where we don't have to go through this really laborious and difficult process and costly process to detect that. That's going to be a key component in, again, managing spread, identifying people that are infected, so that hopefully within a year, you'll be able to maybe take a home test, and then if you are positive, then you won't go to work or you won't go to school and stay isolated until you clear the virus.
The scary thing about the illness presently is that when it first came out, it made people extremely ill right off the bat, and you knew it was something that was you could fearfully potentially die from, and you still can die from it. I'm very worried about it as somebody who's over 60. I want to avoid it at all costs, because you just don't know how it's going to affect you. You can make general statements that they've made throughout the course of this, such as children don't get it, or they don't get it as badly, or the older patients are going to die, or the patients with diabetes are going to die. And it's really just about impossible to predict who's going to get sick enough to die. There are definitely populations of patients who are more at risk. Patients with diabetes, patients with chronic heart and lung diseases, patients with immunocompromise who can't mount an immune defense to this. They are certainly at a greater risk of having a severe illness. And what we have seen more recently in the last 2 months is that the symptom complex has changed. Initially, the symptom complex was high fever, like the flu, shortness of breath, and cough. And that was ubiquitous. That's what you had when you came in with COVID in March of this year. What we see now, it's the symptoms have just completely morphed into now it can be like an allergy attack. People have nasal congestion, scratchy throat, and post-nasal drip and sinus drainage, and they're turning up COVID positive. And they don't ever get really, really sick. But within that scope, there are still a lot of people who get really, really sick, as manifest by the fact that our population of patients in the hospital has not gone down.
Well, the reality is that this is a new virus, and we're still figuring out the biology of this virus and how it works or how it infects people. And we're literally learning things as we go. And so we have no way of knowing for sure what it's going to look like next year. Because we don't know how it affects folks, long term. So viruses and other microbes, other germs, one of the key features they have is they multiply at a rapid rate, and while they're multiplying or reproducing, there are mistakes or errors that happen in their genetic material that basically allows them to change.
We've noticed now that people may develop pure gastrointestinal illnesses. They may purely have nausea and diarrhea. And whereas before that was never even considered to be part of the COVID illness.
And we can easily monitor the virus after it mutates because we have molecular techniques that allow us to look at its genetic material and literally just read the sequence, and we see those changes. And then a lot of work can go into studying why these changes caused, a change in its behavior or how it causes disease, but we cannot predict it ahead of time. It's something that basically always done after the fact. But one of the promising things is that a lot of people are working on vaccines. If one of these vaccines is successful, that there's a really good chance that we can control this pandemic and fewer people will be infected by it. This is probably going to be one of the fastest, one of the vaccines that's going to be developed faster than any vaccine in history, just because of the level of interest and the number of companies and institutions that are working on developing this vaccine. So I am very confident that we should have a working vaccine within a year.
Now what we're faced with is managing our healthcare resources. Early on, it was evident that our community responded very well to the mayor's request to tamp down the curve, flatten the curve you've heard mentioned before, meaning that we were going to try and stem the tide of COVID-19 patients in our community so that we didn't overtax the healthcare resources.
Let's remember that coronavirus is making a lot of people sick, and it doesn't seem to be slowing down. But people are still getting sick from everything they used to get sick from. So the other viruses and other illnesses and cancer and other stuff has not gone away. People still need a lot of care.
That makes it difficult for people to get a hip replaced or a knee replaced or needed spine surgery if they're having back pain. Those things that aren't emergencies, but they do pose a complication in life and cause pain.
And so again, this is why there's a lot of concern about the fall. We're hoping that between now and the next few months that we will mitigate this spread and get it under control, because we need to do that, but also to avoid a coincidence between high number of cases of coronavirus and high numbers of flu cases and other respiratory tract infections.
So we want our patients to be able to have access to needed medical services every day that they need it. In order to do that, we are asking that the citizens in our community pay as much attention as they can to the appropriate things they can do to avoid contracting COVID illness and requiring future hospitalization. Doing the things that you've been asked to do, appropriate social distancing, wearing a mask when it's appropriate, avoiding large gatherings, anything you can to reduce the spread of this illness will help us reserve resources in the healthcare environment to take care of the day-to-day illnesses that plague us as part of our daily lives.
Many times in public health, we ask people to either perform certain behaviors to protect themselves or others, or we may ask them to stop certain behaviors to protect themselves or others. And we've seen this in COVID-19 as well. We've started asking people to please social distance, to please wear a mask, to please avoid social gatherings of a certain number of people. So we've asked them to stop doing some things as well, right? So to start and stop things, and these behaviors can help prevent the transmission of the virus.
Despite all the challenges we're facing with the coronavirus pandemic and all the ways that it has affected our lives, I am hopeful in the sense that we have a lot of professionals working on it, from medical doctors to scientists to nurses and public health professionals. And there's a lot of knowledge that we're gathering every day. And so the scientists, the professionals are working day and night to do their part. I think the average person or the public can help tremendously by just following some of the preventative measures to mitigate spread. And that would go a long way in us basically controlling this pandemic and hopefully going to some level of normal.